Am I audible?
Yes, ma'am. Perfect.
Can I share the screen, please?
Sure, ma'am. You have already have the access.
Once again, thank you. And I'm meeting you again in less than a week's time. Okay. And this time we are shifting gears to move into the fast gear. And that is the management of difficult pain. Okay. So I just share my screen 1 second. Uh,
And by the time Mary ma'am shares her screen, happy Teachers' Day to all the wonderful faculties out there and those who are hoping to become faculties in the future. All the best.
okay. So I will now talk about how to approach a patient with difficult pain. Like I mentioned in my earlier talk, that using the WHO analgesic ladder, we are still not able to treat about 15 to 20% of patients. Okay, even with the strong opioids, we are unable to treat them. And so these are the people who are difficult to treat, or what we call as refractory cancer pain. So there are other terminologies for the refractory or difficult pain. They include intractable pain, persistent pain, or opioid non-responsive pain, because we have put them even on strong opioids and they're not responding. So what is the definition of refractory pain? It is pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. It's not uncommon to encounter these people in our clinical practice. And the risk factors for why they go into refractory pain is younger age group people are more susceptible, neuropathic pain is more difficult to treat, incident pain can be very difficult to treat. And besides, if there is psychological distress, then that has to also be addressed to get effective pain management. Then previous opioid use makes them tolerant to opioids, or history of addiction, even impaired cognition. When they are not even able to communicate with you the exact nature of pain, you'll find it difficult to treat them. Okay? So I would like to start with a case scenario. This is a patient I encountered in my practice. He was a 62-year-old man with CA rectum. He had peritoneal and liver metastasis. He was on chemotherapy for 1 year. He initially responded very well, but after 1 year, he developed recurrence of the cancer, which was seen on the PET scan. Subsequently, he developed acute intestinal obstruction with pain abdomen. This was primarily due to progression of the primary lesion. So at that point, he was taken to the emergency room because he was vomiting, not passing stool, his abdomen had got bloated, and he was admitted for conservative management of intestinal obstruction. A Ryle's tube was inserted, a colostomy was done. And he was discharged with the advice of continuing with palliative care. And at that point of time, they decided not to give him any further chemotherapy. Initially, he was quite stable on WHO step 1 and 2 drugs that we were giving through the nasogastric tube, along with adjuvants for pain abdomen, like anticonvulsants. But the abdominal pain persisted, and he was then had to be put on step 3 drugs orally. But one day he pulled out his Ryle's tube and he did not want it reinserted. Initially, also, he did not want the Ryle's tube. But this time when he pulled out, he categorically indicated, even in his very weak and emaciated state, that he doesn't want it reinserted. So we could have easily put it down because it was not difficult to put in a Ryle's tube. But we had a family discussion along with his children and wife as to how to feed him, because he was emaciated, and also we needed to give him the analgesic drugs. But because the patient's wish was that he doesn't have a Ryle's tube, we respected the patient autonomy and decided that we would not put in a Ryle's tube, but he had a chemo port, so we had to just start him on IV fluids through his chemo port, since at that point of time, they did not want to go back to the hospital. But his pain grew worse. And then he had to be started on even transdermal fentanyl patch, along with the because we could not give him oral morphine because the Rayleigh tube was out. And then we also gave him oral transmucosal fentanyl citrate, or the fentanyl lollipops, which is around 200 mics, and we can give it SOS basis. But still there was no relief of pain, and he was writhing and shouting in pain. At this point of time, the family was extremely distressed. So what do we do next? So that is what we will go through when I run through this case presentation. So the steps that we need to take for difficult pain is, first, we have to review the patient. Then we have to manage with either pharmacological or non-pharmacological options. So in the pharmacological options, we can either convert the route of the drug administration, or we can rotate the drugs, what is called a switch, or we need to add further adjuvants depending upon what type of pain he is, which I think I talked about it in detail in my last class. The other thing that we have are the non-pharmacological options, in which we can go in for interventional pain management, the psychological therapies that we need to address, physical therapy, alternate therapy, or maybe even spiritual therapy. So in the step one, we need to review the patient, and it's easy to remember the mnemonic ABC. A is adherence to treatment. B is believe the patient about pain. It was Margot McAfee in 1968 who said that pain is whatever the experiencing patient says is existing whenever he or she does. In simple terms, pain is what the patient says hurts. Then we need to do a comprehensive pain assessment. We know the various components of doing a comprehensive pain assessment, which include eliciting the pain characteristics, reviewing his functional history, in the sense that is he able to sleep, is he able to walk around, is he able to carry on with his daily activities, review the prior drug and non-drug history. Then we need to examine and again review the patient. And the next C is to correct the correctable factors. So if there is a pleural effusion or if there's an ascites, we need to tap it. That can cause a lot of relief of pain. Or we need to treat any underlying superadded infections. Or there could be insomnia. Like I said, when there is sleep disturbance, it reduces the threshold for pain. And the patient can feel more pain. So we need to treat the insomnia, the anxiety, the nutritional status. I think you all must be familiar with the gate control theory of pain, right? So where even factors like anxiety and lack of physical activity can open the gate for the C fibers to transmit the pain into the spinal cord and the brain. So they also act like a opening the gate, okay? And these are the things that we need to review. Now, adherence to treatment. In this, we need to go through the analgesics and review the adjuvants. Quite often you find that when you tell morphine 10 mg, say for example, this prescription 10 mg 4 hourly, they may not give it at every 4 hours. They may not realize the significance of giving it every 4 hours. So they will be giving it when the pain comes back, or they may not give the SOS dose, that is a rescue dose that we need to give if the patient has pain even in between the 4 hours. So they may not have understood it properly. Then we have to, that's why we need to check the patient's understanding of the dosing regime. And for that, a simple thing is to use teach-back techniques. Ask them, either the relative or the attendant, to tell what exactly and how they are giving it. So we will know whether they have understood what has to be given at what time they have to give. Okay. So adherence to treatment is very important. Very common cause of pain not responding to your therapy. The other reason could be the ineffectiveness of opioids that you're giving, the strong opioids. And the most common reason is the accumulation of toxic metabolites. We know that morphine and all get metabolized to morphine 6-glucuronide and 3-glucuronide, and it's the 3-glucuronide that causes the metabolites that can cause the side effects. Okay. The second is the progression of the disease. That's a very common cause for a refractory or difficult to treat pain. I will talk about this particular patient that, you may need to add more therapies if the disease has progressed more. Or is there a new pain type? Is there a neuropathic component that was not there earlier? Or is there a bowel obstruction, as in this patient? Or is there spasticity? So these are the new pain types that are there, which we may need to add another adjuvant drug. Then it's possible that there could be intolerable side effects. Like with morphine, you can go have neurotoxicity, manifesting as sedation, delirium, hyperalgesia, or myoclonus. And then we are not able to take it up further. So you may have to think of other options. Or is there a failed route of administration? Is there a poor oral absorption? Like if a patient is having intestinal obstruction, or if the patient is having a gastric outlet obstruction, the drug that you're giving is not getting absorbed. Or is there a diminished transdermal skin absorption? See, these are the things that you need to think over. Or is there a system malfunction, like a pump not working effectively, or blockage of the needle, or is there a catheter malfunction, which could be with either the intravenous route or the subcutaneous route, or even with the spinal route. And last but not the least is, are there any superadded psychological, social, or spiritual factors which we need to address if you really want to manage that pain? So like I mentioned earlier, we have both pharmacological and non-pharmacological options. So let's discuss the pharmacological options for difficult cancer. So the first thing we need to remember is we need opioid manipulation. Now we know that the patient is taking strong opioids, but it is not effective. So whether we need to convert the route or we need to switch the opioid drug. And then whether we need to add an adjuvant drug, which I talked about in great detail in the last presentation, so I won't talk about it, but we may need to add an adjuvant. Now coming to opioids. Now, route conversion. It is the same opioid, but you're giving it from a different route. For example, you were earlier giving morphine, but now you have to switch over to the intravenous route of morphine administration. Maybe that would be more effective for him. Or if you're giving a transdermal fentanyl patch and it is not working, you may have to move to the intravenous fentanyl infusions, right? So high serum concentrations can be achieved by both intravenous and the subcutaneous route. Both are equally efficient in getting the desired effect. And we can give both morphine and fentanyl through the intravenous and the subcutaneous route. And just remember the conversion factor from oral to subcutaneous to intravenous, it is 3:2:1. For example, you're giving 30 milligram morphine orally, then subcutaneous dose would be 20, equivalent dose, and intravenous route would be 10. So just remember 3:2:1 is the conversion factor. Now, if you want to give intravenous opioids, you can give it either as a continuous infusion, fixed dose infusion. Okay, that you give it for the continuous pain. But if the patient has a continuous pain as well as a breakthrough or an incident pain, then you may have to give an intermittent bolus. So for that, patient-controlled analgesia is very effective. It treats both continuous as well as the incident pain. And it allows the patient to even self-administer the parenteral opioids. So you can set a baseline infusion and add a bolus dose for the breakthrough pain. And for that, you have a remote which the patient can control with his own, on his own. We have got both disposable elastomeric pumps in which the whole infusion is filled up into this balloon, and there is this remote that is over here. Or you can have the continuous ambulatory drug delivery system. So these are not disposable, but you have to fill in the drug into a chamber inside this. And this also has a remote which the patient can use. Now, oral versus parenteral opioids. There is no evidence of the superiority of parenteral versus oral opioids to control intractable cancer pain. But the European Association of Palliative Care do recommend that parenteral opioid infusions may be used where oral or transdermal opioids are ineffective in reducing pain relief. The other method of opioid manipulation is an opioid rotation. Okay. The opioid rotation is you're giving the same opioid, you're giving the same route, but a different opioid. For example, you're giving oral morphine, it is not effective, you switch over to oral methadone. The indications are either intolerable side effects due to neurotoxicity or poor analgesia despite titration. So then you can't step up on the oral route and you may have to change it to another opioid drug. So how does that work? That works because of the incomplete cross tolerance. Because among the opioids also, all the opioid receptors are not activated by a particular opioid, and there are still receptors that are receptive to other opioids. That is called incomplete cross tolerance. And because of that, you have greater than anticipated potency with another opioid. Okay. So when you convert from one opioid to another, there are three steps that we need to take. First is you have to find out what is the equianalgesic dose. There is a table that is widely available. You can look it up. But as a simple way is, if you're giving 25 mics per hour of fentanyl, that is equivalent to 60 mg morphine. So based on that, you can calculate what is the dose of fentanyl or whatever drug that you need to give. And once you calculate it, you don't give the entire calculated dose, but in patients with well-controlled pain, you give 50% of that calculated dose. And if it's a poorly controlled pain, you give 25% of that dose. The only exception is methadone, and I will talk about that later on. And besides that, you also need to prescribe a rescue dose as well. Now, I already mentioned about opioid-induced neurotoxicity. It is because of the metabolites of morphine, which include morphine 3-glucuronide and normeperidine. And these are all which I've already elicited the signs of neurotoxicity, by which we cannot go up on the opioid, right? We have to either switch over or change to a different. Now, the other thing is, in India, the only drug that is available in lieu of morphine are methadone and fentanyl. Okay, they are the only step 3 drugs that are available in India. Outside, you've got other drugs like oxycodone and the other drugs, other opioids are also available. Now, methadone is inexpensive and can be given orally, but remember that they are all under the same legal control as morphine. So what are the advantages of methadone for difficult pain? I think this will be discussed in a separate class, but I'll just briefly go through it. First is, I think it has already been discussed, if I'm not mistaken. Step 3 drugs would have already been discussed. So it's highly potent. It is effective for neuropathic pain also, much more than morphine, because it not only acts on the NMDA receptors, but it is also a serotonin norepinephrine reuptake inhibitor. Then there are no known active metabolites of methadone. It has a long half-life, so the number of doses also can be much less, slowly eliminated, and there's less risk of breakthrough pain. It does not accumulate in renal impairment. There is less tendency for tolerance and no cross-tolerance, and it is also relatively inexpensive. But there are side effects and disadvantages of methadone. The first is the risk of life-threatening ventricular arrhythmias, particularly if there's a QTC prolongation on the ECG. That's called torsades de pontis, which is quite dangerous. Okay. And the second thing is titration is difficult, and there could be a risk of overdose because a half-life can be variable. And it's recommended that only experienced palliative care specialists give methadone and not the novices in palliative care. So what are the indications for methadone? The first and foremost is for opioid rotation, like I told you. Also, cost-wise, it is a very inexpensive drug. When there's true morphine allergy, you may have to give methadone. When there is coexisting neuropathic pain or if there's a renal dysfunction, then methadone would be preferable to morphine. But the contraindications, like I mentioned, are if there's a QTC prolongation on the ECG, if there's no reliable caregiver to give the methadone, if there's a history of sudden unexplained death in the family, and because of the drug interactions with drugs like azithromycin, fluconazole, and amitriptyline, we need to be careful when you're giving methadone. So I wanted to mention about about how to convert morphine into methadone. If you're giving a less than 60 mg morphine a day, then the oral morphine equivalent is around 2 to 7.5 mg of methadone. But if it is between 60 to 199 OME, or if the patient is less than 65 years of age, then the conversion ratio is 10:1. That is, if you're giving 10 mg morphine, you give 1 mg oral methadone. And if you're giving more than 200 mg of morphine, and if the age is more than 65 years, then the conversion is 20:1. So that means for 20 mg morphine, you give 1 mg oral methadone. So it's available as 5 mg tablets and syrup as 5 mg per ml. So as per expert consensus white paper, the equianalgesic dose suggested for methadone are very conservative. So we need not reduce the dose to account for incomplete cross tolerance. So whatever you're converting, that can be given according to what I just mentioned. And switching to methadone from other opioid analgesics are safe and effective. It was found in a prospective study. The other strong opioid that you can give in lieu of morphine is transdermal buprenorphine. Okay? So that is another option for opioid rotation. It can cause better pain relief. It has good tolerability. It can control neuropathic pain and also breakthrough pain much better. And the patches are Duvalor patches are available. You have two strengths. One is 2.5 mics per hour and one is 5 mics per hour. And each patch lasts for about 7 days. Now, having talked about the drugs, let us now review the cause of pain once again. Is it nociceptive or neuropathic, or is there a need for an adjuvant drug? This I've already talked about, that where nociceptive pain is perceived and how is neuropathic pain perceived and what is mixed pain. So I'm not going through that. Ketamine is one of the options for difficult neuropathic pain. You remember I told that neuropathic pain is difficult to treat. So ketamine is one of the options that we can consider, particularly when they're unresponsive to antidepressants and anticonvulsants. So I've already discussed this. It can be given through a variety of routes. And the route that you can use is either oral ketamine or subcutaneous or intravenous ketamine. Then there is an option called burst ketamine or a pulse course of ketamine. That you give it, you start off with 100 milligrams in 24 hours and you give it for 3 days. And if that is not effective, then you can step it up to 300 mg in 24 hours using a syringe pump. And if that is not effective, then you can go up to 500 mg per 24 hours. Do that for 3 days. If it is not effective, then you have to stop. But that is called the burst ketamine. It's one of the options to treat refractory neuropathic pain. But the side effects, I've already dealt with this earlier, so I'm not going through this slide. And then we have the other option for treating difficult neuropathic pain, which is the local anesthetics. And they are reserved as a second or third line option to treat severe intractable crescendo kind of neuropathic pain. And this also I've talked about earlier, how you give it as an IV infusion of Xylocarb, 5 mg per kg, and you add it in 500 ml of normal saline and give it over 1 hour using a syringe pump. Of course, remembering that it has to be done in a hospital setup with cardiac monitoring, or you can even use the lidocaine patches that are available. 5% lidocaine patches are available. You can also have topical drugs to treat neuropathic pain. They include topical capsaicin, 8%, but they are not freely available in India, or even topical gabapentin. Okay? So these are the topical neuropathic drugs that you can use to treat the difficult pain. This also I showed in my last presentation. The first line treatment is amitriptyline, pregabalin, gabapentin, duloxetine, and lidocaine patch. Second line treatment are opioids and tramadol, and among the opioids, methadone is a preferred option. Third line, you can use drugs like baclofen, mexiletine, capsaicin, ketamine, or cannabinoids. So let's discuss cannabinoids in the management of difficult cancer pain. Now, this has been used for ancient times to treat various ailments. But in medicine, the use is restricted because due to the drug misuse. But in palliative care, a few symptoms are resistant to the current options that are available. So, despite the lack of robust clinical data, which shows a favorable risk-benefit ratio, we have still included it in the armamentarium of the palliative care doctors. It is yet not routinely included in palliative care. Now, the endocannabinoids, which is an ingredient present in cannabinoid, they act on two receptors in the CNS, which is a CB1 and the CB2 receptor. Now, CB1 receptors are found in the brain, the spinal cord, the peripheral nerve, leukocytes, endocrine system, and the various organs, but they're poorly expressed in the brainstem, and that is the reason there is a low incidence of respiratory depression with cannabinoids. But because of this one, CB1 receptors, that is how we are getting the psychotomimetic effects of the cannabinoids. That is the high and the euphoria and all those effects that you get with the cannabinoids. Now, CB2 receptors, on the other hand, are mainly found in the immune system. They have no psychotomimetic effects, and they are now being investigated for the therapeutic effects, like the analgesic effect, the anti-inflammatory effect, and the anti-neoplastic effect as well. The two phytocannabinoids that have been extensively studied are THC, which is delta-9 tetrahydrocannabinol, and CBD, which is cannabidiol. Now, nabiximol or Sativix is an oromucosal spray which contains a 1:1 combination of THC and CBD. Okay. THC is a psychoactive component and CBD is the one which has the anti-inflammatory property. And they have been found to be well tolerated and causing improved analgesia, particularly in opioid unresponsive cancer patients. So the preparations that are available, the one which are having THC as a main ingredient are dronabinol, which is a synthetic THC. It's available by oral route, 5 milligrams per capsule, or nabilone, that is also a synthetic THC, again oral route, 1 milligram per capsule. Then you have the CBD dominant cannabinoids preparations, and that includes a 99% pure oil-based cannabidiol, in which the dose is 5 mg per kg per day. Okay. And then you have, like I mentioned earlier, the combination of THC and CBD, which is the one that is available is the nabiximol, which is a 1:1 ratio. It's an oromucosal spray. So each dose is 2.7 and 2.7. Okay. But remember, all these drugs come under the category of the Schedule 1 drugs with a high potential for abuse. So the analgesic effect of cannabinoids are comparable to the weak opioids like tramadol. Okay. And when you give a dose of 15 to 20 mg THC, the peak effect is seen in 3 hours and it lasts up to 6 hours. So you may have to give it every 6 hours. So it can be used as a third or the fourth line treatment for neuropathic pain when the conventional therapies fail. If you want to compare the equianalgesic dose with codeine, then 20 mg THC is equivalent to 120 mg of codeine. It's also used for treatment of chemotherapy-induced nausea vomiting, where you can use both dronabinol and nabilone. I won't talk about this because this is outside the purview of my talk, because it's a treatment of nausea vomiting. So I'll just skip both these drugs. Just remember that both these can be used for the treatment of chemotherapy-induced nausea vomiting. Now, what are the side effects of cannabinoids? The first is, like what we know, is the neuropsychiatric effects, that it can aggravate the pre-existing anxiety, schizophrenia, and depression. It can cause impaired cognition because of the excessive sedation and impaired motor skills. There is a risk of infection because it can reduce the host response. And we have the cardiovascular side effects. And so you should avoid it in patients with heart disease. So what are the uses of cannabinoids in palliative care in a nutshell? It can be used as an analgesic, as a third and fourth line treatment for neuropathic pain. It can be used for chemotherapy-induced nausea and vomiting because it acts on the emetic reflex pathway of the brain. It can be used for cancer anorexia, for HIV-related cachexia, for multiple sclerosis associated spasticity. It improves mood and the antipsychotic effects. And it has also got anti-cancer activities, help in sleep disorders, and it can also help when there are seizures as well. Now, this was a study that appeared very recently in May 2022. Medical cannabinoids to reduce the pain in cancer patients. And they found that medical cannabis has significant improvement in pain measures and a decrease in other cancer-related symptoms. And it reduced the consumption of opioid-based analgesics, and the side effects were minimal. So they do recommend cannabis, particularly in those who are on opiates. What about the legal status of cannabinoids in India? What is the current status? We know that it is approved for treatment of a variety of conditions, including multiple sclerosis and refractory pain in cancer abroad. But in India, there was a petition in the Delhi High Court challenging the provisions of the NDPS Act, because in the NDPS Act, even cannabinoids is banned. So they have said, the petition said that it should be legalized for medicinal purposes. And the central government has informed the court this year that cannabinoids is allowed in India for medicinal and scientific use as per law, and it is not completely banned. Now, corticosteroids. I can even skip this slide because I just dealt with all of this earlier. So I think I will just skip. Okay. This has all been discussed in my previous presentation. Again, just remember that corticosteroids is also one of the options to consider in difficult cancer pain. GABA receptor agonists, like GABA A receptor agonists like clonazepam, can be used for neuropathic pain, and GABA B receptor agonists like baclofen can also be used for neuropathic pain as well as for pain associated with spasticity, which are difficult to treat. So that is what I have mentioned over here, that it can be used for refractory neuropathic pain. Now, bone pain, that is yet another cause of refractory cancer pain. And we have the various skeletal related events that happen, including fractures, and they can be very, very agonizing. And so these are the various drugs that we are using to treat bone pain, which I've also discussed in my previous presentation. Then we have a malignant bowel obstruction, which can be a cause of difficult cancer pain, like in this case that we have just presented also. So they can be inoperable. And so the drugs that we can use are octreotide, which is a synthetic hormone. It's a somatostatin analog. How does it act? It decreases the splanchnic blood flow, portal blood flow, GI motility, and decreases the various secretions in the bowel and increases the water and electrolyte absorption. So you give octreotide in a dose of 300 mics in 24 hours, either as a subcutaneous infusion, okay, for 6 days. And the Multinational Association for Supportive Care for Cancer guidelines have recommended octreotide as a drug of choice in malignant bowel obstruction. And it can be combined with anticholinergic drugs like hyoscine and steroids as well. Now coming again to we have already discussed all the pharmacological options. So what are the non-pharmacological options? I've shown this particular slide in my earlier presentation. These are the step 4 options that are available to treat the difficult pain, which occurs in about 15 to 20% of patients with cancer. So the various interventional procedures that we can do are giving a PCA pump, nerve blocks, epidural blocks, or you can go for peripheral neurolytic procedures using either alcohol or phenol. You can go in for intrathecal opioids and spinal cord stimulation. So these options are considered in patients with severe side effects from drugs whose life expectancy is more than 3 months. But you also have certain procedures which are called the central neurodestructive procedures. They include rhizotomy, gangliotomy, chordotomy, myelotomy, tractotomy, thalamotomy, or operations on the limbic system like cingulotomy. But they are very high-risk procedures, and they are rarely done when the life expectancy is more than 3 months. So it is only when it is less than 3 months that you have to think of these procedures, because the risk benefit ratio is very high. And we need to assess that before we go in for these things. I've never seen any of these procedures performed. Although I'm a neuroanesthetist, still I've not seen any of them. Among the non-pharmacological therapies that are available, we also have dry needling, acupuncture, biofeedback, psychological therapy like reassurance and counseling, physical modalities, and spiritual therapies and alternate therapies. Now, dry needling, that is one of the modalities you can use for difficult cancer pain, particularly when there are muscle spasms and myofascial pains associated with cancer. So in this, the tender myofascial trigger points that are in the affected muscles can cause a lot of pain because of the sustained contractions. This you can even have in patients with pancreatic cancer because of the spasm that is there. So how do they act? How does dry needling act? It acts by producing reflex relaxation of muscles and improves the hypoxic local energy crisis due to the sustained contraction. There's a lack of oxygen, and by needling them, you're promoting the blood supply into these areas that are ischemic. And it also releases the trapped inflammatory mediators that are caught in the taut band or in the trigger point. Now, physical therapy modalities are ambulation and musculoskeletal therapy, neurological therapy, electrophysical agents, mechanical therapy, and education, and a whole lot of options are available. So physical therapy is also very important in cancer pain, particularly when it's refractory. And then, of course, we have the psychosocial and spiritual issues, because cancer causes a lot of fear, anxiety, depression, anger, guilt. There are a lot of financial issues. There is fear of the future, concern about loved ones, loss of role or role reversal, and even questioning God. So you have a lot of therapies that are available, which include counseling, CBT, that is cognitive behavior therapy, communication skills, medicines also like antidepressants, support groups like art therapy, music therapy, dance therapy, and providing financial support for the patient's needs, including the children's education. So now let us come back to the case that we discussed in the beginning. This gentleman had refractory pain that was not responding to the domiciliary use of step 3 drugs. So what could the possible causes be? Could it be due to medical reasons because of the progression of disease? The colostomy site definitely looked unhealthy. Or was there a failed route of absorption? Was there poor oral absorption of opioids? And in this patient who was getting a fentanyl patch, was there decreased transdermal fentanyl absorption? Or were there other psychosocial concerns? What did we do? We had to readmit the patient to the hospital. It was found that the colostomy was non-functional, which was the obvious cause for severe pain. In fact, it was necrotic. That must have caused him a lot of pain. The opioid route conversion was done. This, we did not do an opioid switch, but we just converted the route. He was started on fentanyl infusion with supportive care. The pain subsided. End-of-life care was instituted, and this was explained to his relatives, and the patient expired free of pain 2 weeks later. So what are the non-pharmacological interventions? Were we too drug-centered or interventional-centered in our approach? Could we have chosen some non-pharmacological options to treat this gentleman? So among the non-pharmacological causes were the psychosocial concerns in this patient. Now, he happened to be a retired, highly educated doctor. He had no financial concerns because the cost of treatment was fully covered. He had a supportive family, his wife and daughter, extremely supportive. They took care of all his needs, including the financial needs, his personal needs, every kind of need. His wife was a main caregiver, and she had even taken over the role of the head of the family, managing all the issues that were related to his medical needs and financial needs. But there were a lot of psychosocial concerns in this patient. First of all, he was depressed because he knew that there was no cure and he would not live long. So there was a sense of hopelessness, helplessness, and powerlessness. He could not do anything about it. Then he experienced loneliness and isolation. It was during the COVID times, but along with that, he himself withdrew from friends and relatives for 2 years. He had a low self-esteem. He was totally dependent on his wife, even for his own self-care activities. He had already developed a ischiorectal abscess. He was, the colostomy had to be taken care of. He had to be, even the personal needs had to be taken care of, like giving a bath and everything. All was done by his wife. He had a sense of guilt because the family had given up all their activities. The wife had given up her job so that she could be his full-time caregiver. It must have produced a sense of guilt. And very important, there was a role reversal. He was the head of the family, but now his wife had taken over all his responsibilities and he was helpless and powerless. Okay. So there were a lot of psychosocial concerns. So all that had to be taken care of in addressing that difficult pain that this patient was experiencing, along with the medical aspects of it. So if you look at this chart, you can see the various drugs that are given. And at every stage, you need to give psychological therapy, okay? Whether it is the step 1 drugs, step 2 drugs, or the step 3 drugs. We need to add psychological therapy at every stage. And then you can go in for the next kind of interventional treatment, which include the intrathecal opioids and all the nerve blocks and procedures. And last is a central neurodestructive procedures, which of course I said is more risky than the benefits. Now, if everything fails, then you must consider palliative sedation. And then you can accept failure, but you should never desert the patient. You should show that you are there with them in their difficult journey. And we should be frank about failure, but you should convey it with sensitivity to not only the patient, but to the relatives also. But we should at all times continue the psychosocial and spiritual support. And if there's any worsening condition, then we need to address it. So that's the end of my presentation.
Thank you, ma'am. Thank you so much. And believe that we have a couple of questions waiting in the chat box. Since Sri Devi ma'am is not joining us for the day, maybe I can read it out and you can take up the questions, ma'am. First question is from Dr. Barul. Is there any specific time frame to call it as a difficult pain? Dr. Barul, would you like to unmute and give more insight to the question?
I got the question. I understand. So see, we have to keep stepping up the drugs. And I think that if it doesn't work, because whatever drugs we are giving, we know how long it takes to act. If it doesn't act in that time frame, then we should think of it as a difficult pain, and we have to, because we can't allow the patient to suffer indefinitely, right? So that we have to take a call.
Next question is from Dr. Roshan Kumar. Do we need to ask for LFT or RFT before opioids or every time?
See, if you do, you remember these patients are all terminal cancer patients. There is no point in going on getting investigations done. Invariably, if these things are done in the last couple of weeks, I don't think we need to get it again and again. We are not going to achieve anything. Because at that time, our main aim is to reduce the pain and not look at the nitty-gritties of the LFT and KFT. Sometimes when they're delirious, you can ask for things like sodium, because sodium is one of the important causes of confusion and delirium. So you can ask for electrolytes, or you can ask for a CBC if you suspect any infection, which may need an antibiotic. But getting these tests done more than once in 2 weeks is really not necessary.
Thank you, ma'am. The next query is from Dr. Suranjan. He wants to know 2 points actually. Do we need to check baseline parameter beforehand to start analgesis? And do we need to check parameters at regular intervals?
I think I answered that. You can have a baseline because invariably these people will be under the oncologist and they would have definitely got all these tests done. So you need to only look back in the file and see whether it has been done in the last couple of weeks. Like I said, the very important thing is maybe a total count or sodium if required. But other than that, we don't need to keep getting, or if there's a urinary infection, which we come to know from the total count also. So other than that, we don't have to do it on a regular basis. Because at this point of time, I don't believe there's a going on, poking them and taking blood out for the investigations is really not required. We have to provide them relief. Of course, if there's a contraindication to morphine because of a kidney dysfunction, we can think of other options. But otherwise, we don't have to fine tune it too much.
Thank you, ma'am. Dr. Roshan Kumar wants to know if there are any terms called as resistance in opioids and wants to know can we re-challenge with those after a specific period?
I think I talked about it in my slide.
Yes, ma'am.
Into opioids. And in that case, there is also that. Then in that case, you have to think of other strong opioids also. Okay? If there is a tolerance to opioid or if there's an allergy to opioids, like morphine allergy, then you can think of drugs like methadone, fentanyl, or buprenorphine.
The next query is from Dr. Brinal Dev. If a patient is having good pain relief from oral morphine, how long can we continue it? And if needed, when do we need to do morphine rotation?
You can keep continuing it if they're having good relief. You don't have to rotate the morphine because morphine is one of the easiest drugs to give. As long as they don't have neurotoxicity and they are not resistant to morphine and not tolerant to morphine, you can continue with morphine. There's no problem. And if the renal parameters are all right, you can continue.
Thank you for answering that, ma'am. Moving on, Dr. Suranjan again wants to know any kind of recommendation of de-escalation of analgesics when pain is under good control.
Yes. I don't have any personal experience, but definitely you can de-escalate the dose if the patient has good control and if they responded to the chemotherapy and the disease is under control, then you can de-escalate the dose. But again, like you escalated the dose every 3 to 5 days, even de-escalation should be done in the same manner. Don't do it suddenly, but try to reduce the dose slowly and see if the patient is still having good pain relief.
Thank you, ma'am. Dr. Prakar Yanesh wants to know, is there any role of dexmedetomidine infusion?
See, I've used dexmedetomidine for anesthesia. I've not used it in palliative care. So I don't have any experience with dexmedetomidine in palliative. It is a conscious sedation. Maybe we can look, it has a role during end-of-life care because it is a conscious sedation, but we don't want the patient to be conscious. We want them to be sedated during end of life. So I'm not sure of the use of dexmedetomidine. Maybe one of us could look it up and share our whatever we have found in the next class.
Thank you, ma'am.
It is being used in palliative care or not, I'm not sure. But for palliative sedation, there are drugs that are available, and one of them is clonazepam.
Thank you,
Clonazepam.
And Dr. Baril again wants to know, is difficult pain only limited to cancer pain?
No, it's not. It's not difficult. Any chronic pain is difficult to treat. Remember, chronic pain is not a symptom of a disease, but a disease in itself. And it can cause a vicious cycle and it can be very difficult to treat sometimes. So again, in that chronic pain also, you have to look at all the other factors. Like I said, in total pain management, you have to look at the financial, social, spiritual factors, everything, and the psychological factors. So they're very, very common to find difficult to treat patients in chronic pain.
Thank you, ma'am. Maybe we can take one or two questions more before moving on to case presentation. Dr. Kapil Mohan wants to know, is there any role of deflazacort, steroid with better side effect profile?
Which one?
Deflazacort.
I didn't get it.
Deflazacort.
Deflazacort, madam. DEFLAZACORT.
Deflazacort, I've not heard about it. Can you enlighten me on
This is
that?
steroid with better side effect profile, ma'am. This is steroid.
Okay. Spelling is?
DEFLAZACORT.
I have no idea. I've not encountered it.
Dr. Kapil, if you are in the meeting, can
Why
you?
don't you share your experience with that?
Yes.
Who asked the question?
Dr. Kapil Mohan.
Kapil, can you tell about that? I mean, we would like to know about it also. Kapil, you can unmute and tell us about it. Where is it given? Because I have not encountered it in my. Anybody else who can tell about that drug?
And we usually use it in refractive rheumatoid arthritis cases all.
Okay.
In case of allergy also, in case of allergy, severe allergy, we also give that deflazacort.
I have no experience of that in cancer.
Ma'am, we have used in cases of rheumatoid arthritis or osteoarthritis with intra-articular injections. And that's all I know. Nothing much more.
It's a better side effect profile than.
We have got some homework for the next class. Medetomidine in cancer pain and also about this particular drug.
Deflazacort.
Priya, whatever is discussed, kindly share it with me also.
Sure, ma'am. We'll definitely do that. Moving on.
Physical pain is difficult to treat. Okay. So then just remember, there is no magic bullet in treating chronic pain or cancer pain. It has to be a multi-pronged strategy. There are many people who say, I want to see whether this particular thing works. I said, it's not this particular thing. Unless you do multiple things, it will not work. It is a multi-pronged, multidisciplinary strategy that you need to use for treating either chronic pain or difficult pain. Okay. So that is why I said you have to use a combination of pharmacological and non-pharmacological therapies, right? So along with your drugs, you may have to use alternate therapies, maybe massage therapy, art therapy, dance therapy, dry needling. You may have to use physical therapy, psychological therapy. So all of that needs to be factored in when you're treating any kind of difficult pain, whether it is cancer or non-cancer.
Thank you so much, ma'am. Moving on, Dr. Narendra Palwal. He was asking, can morphine tablet be administered per rectally?
I don't think so. I don't think rectal preparations are available.
The same immediate release can be given per rectally.
Can be given?
Release. Yeah, we are giving in a place.
Okay.
For terminally ill patient, those who cannot take orally, the same 4-hourly medication we can give per rectally.
But what is its bioavailability? Absorption?
It's definitely less than the oral, but it's the same from the mucous membrane. Actually, you need to do a PRE before that, so rectum is empty or not, then or you need to evacuate it, then only you can put it should come in contact with the rectal mucosa.
A patient of mine, because we couldn't give it orally, we had to give a transdermal fentanyl, maybe we could have given it rectal.
No, yeah, it's worked very well actually for the terminally ill patient.
Thank you, Dr. Smita, for sharing that information. Moving on, Dr. Sumita herself has also asked whether Mary ma'am is having an experience with cannabinoids.
Yeah, I did have a patient recently who was, I was giving her oral morphine, and she was also taking along with that diclofenac. She only found relief with diclofenac. In fact, it was even better than the morphine. They did start the cannabidiol, but and even the THC, but the response was not very good. I'm only one patient who did it, but the response was not good, so much so that we had to discontinue. So maybe it will work in some patients, but not in the particular patient that I did. I myself didn't give it. It was being given by a person who was, because I have no experience. So a particular doctor.
Sorry for that, Mary ma'am, you can continue.
What I'm saying is that my personal experience hasn't been good, but possibly that it may be working. But this particular patient, it didn't work out at least. He was taking that CBD oil, not the oromucosal spray, but she was taking the CBD oil and the thing, but it was not very effective, and we had to ultimately discontinue.
Okay. Thank you.
Thank you, ma'am. I think we can take one last question from Dr. Shatarupa. Suppose a patient having oral morphine, but patient party complains about patient is sleeping most of the time of the day. What should we do? Should we reconsider the dose? Am I audible? Thank you for confirming, Dr. Parul. Mary ma'am, do we have you with us in the call? I think you're muted.
Parul is making the presentation?
Yes, ma'am. Yes, yes. Ma'am, just one last question from Dr. Shatarupa. I think we lost you in between. Uh, suppose if a patient having oral morphine is, but the patient party is complaining that the patient is sleeping most of the time of the day, what should we do? Should we reconsider the dose? That was a question from Dr. Shatarupa.
Okay. See, when you give morphine, the patient can be sleepy, but as long as the patient is arousable and not excessively sleepy, and not having any of the other side effects, you can, but then you must be careful when you're escalating the dose. Okay, but they should be arousable. So that is an important thing, that at least they should be arousable. But even if they may be sleepy, and the sleep can also be due to the pain relief that they're experiencing. They may not have slept for a long time. So once you get pain relief, they can tend to sleep a lot. But as long as they're arousable and able to do their normal activities and then go back to sleep, that's okay. But they should not be having any of the other neurotoxicities. So the two common causes for stopping the morphine or stopping the further escalation of morphine is either neurotoxicity or excessive drowsiness.
Thank you, ma'am. With your permission, we will be moving to the case presentation.
Okay.
Dr. Parul.
Yes. Good afternoon, everyone. Happy Teachers' Day to one and all. Am I audible?
Yeah.
Yeah. Happy Teachers' Day, Mary ma'am.
Thank you. I already got a message in the morning.
Yeah, yeah. So here I'm presenting a case of 8-year-old female child whom I'd seen during the pre-anesthetic checkup. She was posted for skin grafting surgery. Diagnosis was post-IM injection cellulitis. Injection was given in the buttocks area. Presenting complaints for the severe pain all over the body. The child was inconsolable, and the child was not allowed to touch for the examination even to the non-affected side. The informant was a father. Patient had the history of fever and cough like 2.5 months back, for which IM injection was given in some local hospital, post which redness and pain was started over the injection site that gradually spread to the abdomen, chest, and the back region. Then she was presented to the hospital in the septic shock, and the emergency surgery was done. Debridement was done, followed by the vacuum assisted dressing, and she was resuscitated and shifted in the pediatrics HDU post-operatively. But since day one, post-operative period, her pain didn't get settled down despite an injection paracetamol, diclofenac injection, and injection fentanyl infusion, which was started at the rate of 40 mics per kg, and it was increased up till 80 mics per kg. Then her fentanyl infusion was stopped, and she was started along with paracetamol and diclofenac with tablet gabapentin 100 mg TDS and injection morphine infusion at the rate of 2 mg per hour. During the course of her 1.5 months of hospitalization, a child underwent multiple surgeries for debridement and the dressing. During the examination, the child was febrile and her vitals were stable, but the child was very inconsolable. And after lots of reassurance, I could little bit examine her, but she was not allowing me to touch. On inspection, I could see the wound over the chest, abdomen, and the back region, and the wound of the chest was extending till the ribs. There was healthy granulation tissue in some part of the areas. Next slide. The current treatment for the child was going on injection morphine infusion at the rate of 2 mg per hour, paracetamol injection 225 mg 6 hourly. Antibiotics were given according to drug sensitivity from the wound culture. Tablet gabapentin 100 mg TDS was given. Tablet clonazepam 0.25 mg HS was given. And including that, to build up the nutrition as the child was hyperproteinemia, injection albumin was added. And prior to the surgery, she had received multiple blood transfusions in her previous surgeries because of anemia. Coming to the psychosocial aspects, the family belongs to a very socio-economical status. Patient is the eldest daughter, and there were 3 younger siblings at the home. And the father was the sole breadwinner of the family, who was a shopkeeper. And since her hospitalization, which was around 4.5 months, the father was not able to work. And mother was also not able to visit the child as the younger siblings were at home. I have medications I've already discussed. The main concern here with the child is the pain, which is very difficult to treat despite on the injection morphine. Coming to the summary, she's an 8-year-old child, 15 kgs, case of post-IM injection cellulitis, undergoing multiple surgeries for the debridement, including the skin grafting, associated with severe pain and allodyna. Points that I want to we discuss in this class is how to manage the pain of this child, and actually how to distinguish the child that she's actually having allodyna, or this is the just the apprehension of the child. And second thing is the child is bedbound, and how to provide the distraction to the child and psychological support both to the child and the father. And anyway, we can help the father with the money aspect or not, since it's not going to work, and does it actually come under palliative care? Thank you.
Thank you, Parul. And now, anybody with any solutions to this problem from your experience? It is a difficult case because of the extensive patient has cellulitis, right?
Yes, ma'am. Yes, ma'am. Post-IM injection should have severe cellulitis. Yeah.
So anybody with any solutions? So right now, can you just once again enumerate the treatments that you were giving for this patient?
Ma'am, she was on antibiotics. According to the culture sensitivity, she was injection on morphine on 2 mg per hour. And she was actually on the paracetamol, gabapentin, and clonazepam, which was given by the palliative care team in the hospital itself. And along with that, she was also getting the supportive treatment like albumin and dexamethasone and yeah, and the laxatives as well.
Someone has talked about switching to methadone in this patient.
It was not available in the main needs. Actually, this is the case. I was working as a senior resident in the Department of Anesthesia in AIIMS Delhi. In the main building, this methadone was not available for the preparation.
And what was the pain score, Parul?
The child couldn't.
Tolerable. So that
yeah.
means must have been at least 9 to 10.
Yes, ma'am. The facial pain score was like 9 to 10.
So we really need to find an aggressive way of managing this pain.
Yes.
Okay. Because, so anybody with any ideas? So ultimately, may I know what happened after this? Like, what was the outcome? And
this was like few months back, actually, ma'am, when it's seen. But then I kept the follow-up of the patient. And I was actually seeing her during the pre-op visits only. And I had attended her surgery for 1 or 2 times. For the distraction technique, I tried to provide her the coloring books, which she liked. I gave her toys, which she didn't found any interest on. Rest thing was, apart from that, I tried to console the father as well, but I realized he was depressive about it as he was not earning. He didn't have a phone actually to let the child speak with the mother or to see any video for the distraction. And with the subsequent skin grafting, and I believe then she found the interest in coloring books and all. And her pain actually gradually decreased along with as the surgery passed away. But yeah, it took around 3 to 4 months for her pain to come down. But during that 2 to 3 months, she was in actually severe agony. I could see that from her face. Yeah.
So that's one good thing that you provided a distraction therapy for her.
Yeah, I tried, ma'am. Yeah.
A lot of things like art therapy and you know, making them do drawings and music and things like that, which can distract them. But you know, when the pain is very bad, even distraction doesn't work actually.
Yeah.
So anybody with any ideas?
Epidural was not feasible for this child because he had actually all the wound over the back, chest. We cannot provide her any regional technique to elevate her pain.
Yes, yes. So anybody with any ideas? Otherwise, I'll come up with my idea.
Yeah, ma'am. I just want to add, if we could have tried a good anti-inflammatory in place of paracetamol, because paracetamol does not have that good anti-inflammatory effect.
Yes,
So
she was on
maybe-
diclofenac. She was on diclofenac along with the paracetamol. I must have missed in the treatment, but she was on. Yeah.
Okay. Okay, that's fine then.
See, there is one therapy that we are using for treatment of burn patients. Burns also causes very severe pain, and particularly during the dressings and even after the dressings. That is called the KTM protocol, ketamine, tramadol, midazolam protocol. Okay, this has been developed by my friend and colleague Lakshmi Vas for treating burn patients in one of the government hospitals in Mumbai, in which if it's a child below 12 years, then you may take 50 mg ketamine, 50 mg tramadol, and 5 mg midazolam. And you add it in 50 ml of infusion and give it at the rate of 1 to 2 ml per hour, along with bolus whenever they require. And they found this treatment to be quite effective in management of these burn patients, because burns also can be very extensive and very painful. And this particular therapy was used to treat these children with burns in the government hospital in Mumbai. So this is what I could think of, after listening to Parul's thing.
Yes, ma'am. We could have tried. Yeah.
Yeah. So it is, all these drugs are safe. Now, along with that, they also gave an anticonvulsant and an antidepressant also. Like you can give Lyrica or pregabalin. In this case, you gave gabapentin, that's fine.
Yeah.
You can even add an antidepressant like amitriptyline.
Okay. Ma'am, gabapentin 100 mg was like for the child of 15 kgs. Is it actually dependent upon the weight, or we can increase the dose?
What you gave?
It was 100 mg TDS she was receiving actually.
I think that's fine.
That's fine. Okay.
Adult, you can go up to 3600 per day.
Okay.
So
Okay.
1200 3 times a day you can give. So I think this 100 mg 3 times a day is perfectly all right.
And what
And-
about the increasing the dose of the morphine? Because the dose was very static for her afterwards, like 2 mg fixed it.
Giving this protocol,
Yeah.
ketamine, tramadol, and midazolam, then you don't even have to give morphine.
Yeah.
Because ketamine is used as a third-line therapy for management of neuropathic pain. And see, when a person has cellulitis, can you imagine all the peripheral nerve endings that are affected, right? So there will be a very strong neuropathic component also to the pain.
Yeah.
So this kind of protocol, in case what you are doing is not effective, I think it's not a bad idea to do this kind of a thing. You can provide good pain relief, and the patient will be comfortable. And then, as and when, like you said, over a period of months, the pain decrease, it
Yeah.
will also decrease, and then you can gradually taper it off. But you can use this along with an anticonvulsant, antidepressant drug.
Okay.
This is one thing I could think of, because it is a difficult pain. Ketamine anyway is useful,
Yeah.
but you can add it with tramadol and midazolam. Midazolam anyway you're mixing with ketamine when you're giving. You can add a tramadol also to it. So this has been published. If you look up, you will find it that this has been published, and they've treated over the years many patients with this particular treatment protocol. Any other questions regarding this case?
Dr. Sumita had
So there will be a lot of psychological trauma for this child. Okay. And in children, these kind of things can cause a lot of trauma, and it can, they need proper counseling. Child counselors are required so that the after effects of this post-traumatic stress disorders don't happen in this particular child. Okay, so please remember that we need to, besides treating the physical pain, we also should treat the psychological aspects and the psychological after effects of pain. Yeah, someone was saying something?
Ma'am, I think Dr. Sumita wanted to confirm ketamine also 50 mg.
Yeah. In an adult, you can go up to 100 mg. In a child, it is 50 mg. In an adult, it is correspondingly 10 mg, 100 mg, and 100 mg.
Okay.
Ma'am, I was asking regarding the father, like how can we support the father? Like, does it come under our palliative care?
See, ideally, it should, we should find ways and means of helping out them in their
No,
financial.
for the monetary reasons, yeah.
Yeah. And in Kerala, I must give full marks to Pallium, who are doing these kind of things. But I don't know how much this is available outside Kerala. But in Kerala, they are taking care of the financial and the social aspects also. And they are providing allowances for them, But I think that should be available all over India. Maybe, it's very difficult, it's a lot of bureaucracy involved and running around to be involved, which they don't have the time to do. The father is with the child, the mother is with the siblings. Who's going to do? So basically, a social worker has to help out in this situation. And they should be engaged just to ensure that the things that need to be done, the running around and the bureaucracy system has to be addressed. It has to be a very active social worker that is involved in this. That is why a palliative care team, it's important, besides a doctor and the nurse, that the social worker also should be actively involved to take care of all the psychosocial concerns.
Thank you, ma'am. Dr. Manisha was saying that as she is not able to meet her mother, that could also be a psychological trauma for her.
So I think during visiting hours, she should meet her siblings and her mother also.
And Dr. Mrinalde was suggesting if there is a local MLA, then they can avail the MLA fund for the financial constraint they are facing.
It is very easy to tell that, more difficult to do it. Very difficult to access them. Okay. And who will do the running around? That's what I'm saying. The social worker is the one who has to take an important role in this matter. The father cannot leave the child alone in a hospital, right? So who will do the running around unless they have a close relative who will do it, or the social worker has. And I know that in places like AIMS, there is a separate department, no, Parul?
Yeah.
That takes care of all these social work and things like that.
Yeah.
Have to
But
be
usually for the post-operative cases, I'm actually not sure whether they get the access or they had that kind of awareness. Like it depends upon the ward doctor as well.
Yeah, NGOs can help.
Yeah.
So there are organizations in Delhi also, like Can Support and things like that. So it's not really a cancer.
Yeah.
Palliative care is, what is the definition of palliative care? Can anyone tell me what's the definition of palliative care? Anybody in the audience? I know this has been dealt with. So can anyone tell me what's the definition of palliative care? Is it only for cancer?
Anyone who is suffering.
It's anyone suffering with a life-threatening illness. Provide total pain management to improve the quality of life. So it could be any life-threatening illness. It could
That
be.
was the question was like difficult pain, because I was discussing something related with the non-cancer pain in my case today. Yeah.
So exactly. So this is definitely a life-threatening illness, which is affecting the quality of life. And so you need to do total pain management. So that is a definition of palliative care. It's a misconception that it is only for cancer. A good case, very difficult, definitely difficult to treat. So we have to think out of the box for this kind of people.
Thank you, Dr. Parul, for bringing in the case presentation. Actually, this is a fast track course, and there was a very short time to bring in the case. And thank you for responding so fast and bringing in.
Thank you.
Any further queries regarding the case or any other inputs? Or any other queries regarding the topic today? Because it is not every day that we get such eminent faculties like Dr. Mary with us. So if you have any queries regarding the topic of pain management, maybe you can definitely ask right away by unmuting yourself or use the chat box option.
The other problem I have found in patients with difficult pain are they move from doctor to doctor. They don't stick to any particular doctor. You give them a medicine, they will discuss with somebody else, go to a different place, discuss with someone else. It becomes a whole, khichdi jaisa ban jata hai, So that is another problem that I find, that people are not adhering to therapy. and they are moving from one doctor to the other doctor. This is particularly more in difficult pain. So that can also be a problem, because they are taking treatment from so many people, and ultimately they may not be getting the right treatment. So that is something that we need to counsel them also, because they are also desperate. You can't blame them, but they just move from one thing to the other. No more questions?
In that case, maybe we can wind up a little earlier for the day. I think Mary ma'am have been having a busy day. I think it's not her day end yet. If any of the participants are not having any further questions, Mary ma'am, with your permission, we can wind up for the day.
Thank you, Parul, for the presentation. It
Thank
was
you
a
so much, ma'am.
difficult one, really a difficult one. And
Thank you, ma'am.
it was good that we got that exposure. And thank you all for the wishes for Teachers' Day.
Thank you everyone for joining in. And we will continue this wonderful journey of foundation course in palliative medicine with more interesting sessions and further eminent faculties. So see you tomorrow with another interesting topic and then yet another eminent faculty. Till that time, this is Sri Priya along with Dr. Mary Abraham signing off from the Tips Eco Hub. See you tomorrow, same time. Take care. Bye-bye.